Ajay Jain has already completed the entire spectrum of complications and their management. However, a few of the things which I like to cover, I'll throw more detail on that. So, as per this study by SIR, the complications which are expected in TIPS, the largest is of hepatic failure. We'll come to all the causes, and the other major complication is of hemoperitoneum. And there are a lot of ways probably by which we can reduce these complications. Maybe use ultrasound-guided puncture technique, which is now being used in more and more centers. Now, what are the causes for the increased morbidity? Maybe it's dependent upon our patient selection. If the patient is already in highly morbid state, the TIPS outcome may not be very good. So the accepted indications for TIPS are gross ascites, which is not being able to be controlled, and multiple drainages are required, or there's a gastroesophageal varicose bleeding that cannot be successfully controlled medically or with the endoscopic techniques. Coming to the patient selection, it's believed if the MEL score is more than 18, the outcome is not very great with TIPS. And the first step, as it is mentioned, for a good TIPS outcome is a good patient selection. So we need to look at the basic parameters of the patient before taking up the patient for the procedure, and accordingly, good counseling for the family should be done, briefing them about what the outcome of the procedure may be. Before a TIPS, if it's an elective procedure, it's a good idea to do a dynamic CT, evaluating the hepatic veins, IVC, and the portal venous patency. However, if it's an emergency bleeder, then you may have to take up the patient just by a Doppler. The other advantage of a dynamic CT is because these are cirrhotic patients. You may have an HCC, and you do not want to transgress a tumor while creating a shunt. Coming to the prophylactic antibiotic, like Dr. Jain mentioned about TIPSitis. To be truthful, I don't think I've really seen any case landing up with infection post-TIPS. That's primarily because if you're careful in the patient selection and you've done the counts and the procal values, if the patient seems to be in sepsis, we should wait. Start antibiotic therapy, let the patient settle down, and then go ahead and do the TIPS. Because in an infected status, if we do TIPS, yes, chances of the stent getting infected are higher. The other thing which was being discussed during the previous talks was that we do not need general anesthesia while doing the TIPS. Very right. We can do it under sedation. However, some of the patients may be very rowdy. You may need 3 or 4 people to pin them down on the table while you're doing the procedure. And this can create complications like stent migration and all those factors. So if you anticipate, or if mid-procedure you see the patient is not getting controlled only with sedation, it won't be a bad idea to convert it into a general anesthesia. Now, coming to the cardiac issues, this comes in the pre-procedure evaluation. As such, there is no consensus which clearly states that these are the right atrial pressures or pulmonary arterial pressures which can tell about a good outcome or a poor outcome. However, the basic guideline which is given is that the right atrial pressure more than 20 millimeter or the pulmonary arterial pressure greater than 45 millimeter give very bad outcome, and probably these patients should be refused TIPS. Now, what are the complications that we can encounter during the procedure which can have effects in the post-procedure period? In some centers, the TIPS is done by wedged venography. Now, there are 2 techniques to do it. Either you wedge your catheter into the hepatic vein, or you inflate a balloon and then do a wedge venography. The incidence of contrast extravasation with CO2 wedge venography is 1.8% and 7.5% with iodinated contrast. This is as per this study published in AJR. So maybe use of CO2 should be encouraged more and more. However, there are not many centers which really have the facility available. And balloon occlusion catheter technique is preferred over the catheter being wedged into the hepatic vein. And in case, now some complication has happened, and if the laceration occurs, which we can see in our venograms, we should assess the patient vitals. Probably you have an anesthetist who is looking after the vitals accordingly, and if there is an ongoing bleed, we need to do a balloon tamponade or if an arterial injury has happened, we need to do coil embolization for the same. Now sometimes while we attempt to enter the portal vein, we may inadvertently puncture the bile duct. So this is actually not a very significant complication. You can see in one of the images which you bought from Dr. Amar. Normally, if this kind of complication happens, we are too busy in handling things and you tend to ignore saving the images. So I really thank him for being very thoughtful at that time to have saved this image. So you can make out the bile duct, and that's the CBD. So that's duodenum, which is well visualized. So this is seen in less than 5% of the patients, and usually doesn't lead to many complications, and you can just come out and attempt another puncture with a different path. However, if a fistulous communication develops or there is hemophilia and later on cholangitis, we may want to do an ERCP and place a plastic stent. And in case there is hemophilia because of an arteriobiliary fistula formation, then we will have to do an angiography to do the embolotherapy for the fistula. That's about the hepatic arterial or the non-target organ puncture. Well, non-target organ puncture is something very rare. The organs which may get involved are the right kidney, colon, duodenum, or the gallbladder. In fact, gallbladder would be seen, I think, more often, though in a very lesser rate, but comparatively. And this happens when the liver is small. Maybe if we have already done a pre-procedure imaging and we are aware about the size of the liver, we'll advance our needle accordingly. But at the same time, as I mentioned earlier, if we are doing the portal puncture with ultrasound guidance, I think we will never come across a non-target organ puncture. The hepatic arterial punctures can happen at times as the hepatic artery travels next to the portal vein. As you can see in this image, that's the tract communication. At the same time, it was diagnosed and angiogram was done, which demonstrated the arterial leak. But once the tip stent was placed, another run taken, the leak had already stopped. So no coiling was required for this particular case. Sometimes we may inadvertently do a portal vein puncture. It may be extrahepatic portal venous puncture. These are the times when we really need to maintain our cool, because once we see frank extravasation of blood from the portal vein, at times we lose the cool and forget some important steps. In fact, we need to be very cool and be very rapid in our action, because we need to deploy the covered stent graft as soon as possible to avoid any further blood loss. If we lose our cool and happen to lose the access, the patient may have to be taken up for surgery to manage this particular complication. This is not, I didn't have any image for the portal venous puncture, so I've just borrowed it from the net. In this we can't see the extravasation, but if you look at the portal vein carefully, the contrast is not very well lining the entire portal vein. So you see heterogeneous contrast uptake, which is probably because of the to and fro motion which is demonstrating the leak. But even in this patient, post deployment of the stent, we can see that the leak had stopped. And the best way to avoid a portal venous puncture is that you plan your procedure well and plan to puncture the portal vein 3 cm lateral to the portal bifurcation. In 95% of the cases, this will be intrahepatic, and the chances of going extrahepatic are very minimal, as the article says, 5%. But then, well, if you're doing this, maybe you will need the ultrasound to guide you. Now we come across hepatic vein IVC junction rupture. This is seen in cases of bud chiari, whereby you are directly making a cavoportal shunt. In the first venogram, you will be able to see the IVC. So the hepatic veins are not visualized. The direct puncture was done. The first puncture did not go into the portal vein. You will see a parenchymal blush in the area. But later on, we managed to puncture the portal vein. But the venogram, that's the frank extravasation. So if you see this kind of extravasation happening, you are worried. But as I mentioned earlier, remain cool, be fast, do not waste time, occlude a balloon, prepare your stents in the meanwhile when the balloon is inflated, deploy the stent, and this is the result of post-stent deployment venogram. So the leak has already stopped. The next important complication, which maybe we see often, is the shunt malposition. So what is the ideal place to deploy the stent? The covered part, if we are using the Viator or the Nitty stents, which are partially covered and rest of it is covered, so the covered part can remain into the portal vein. The uncovered part can remain into the portal vein, and the covered part, the ideal thing is that 1 centimeter beyond your puncture, that can come into the portal vein. If it's more than 1 centimeter, you may be occluding too much of the portal tributaries, depleting the supply to the liver. So that's what we do not intend. That can lead to the liver failure later on. Now the other important thing is that the tract should never be left open. Although a lot of centers in US are using bare stents for tips. I have not prepared this talk, so I have not really gone through what the success rates are. If you ask me, theoretically, I think those stents should occlude pretty fast. But anyway, if they're doing it, so our idea is to cover the portal vein from the puncture site right up to the hepatic vein IVC junction. In fact, we do not even want the covered part of the stent to remain only into the hepatic vein. In fact, some centers in India also cover only the tract part with the covered stent, and there's a bare stent into the hepatic vein IVC junction. But the theory behind covering the hepatic vein IVC junction is that with the increased portal flow, normally hepatic vein IVC ostium, there's stenosis which develops there because of intimal hyperplasia due to high flow, which leads to early stent occlusion. Next thing is the stent migration, which can happen often because the covered stent graft is more difficult to handle. But if this happens, we can try, if we are using a Nitty or a Viator stent, you have the option of catheterizing the stent and repositioning it. However, if you are using combination of a bare stent and a covered stent separately, it may be a difficult scenario. As it was shown in this particular study, that the stent which has gone way below their intended area. So what they have done is inflated a balloon into it, taken a snare, captured the balloon into the snare, and pulled the stent. But this all needs to be done very carefully, as if the struts get stuck into the hepatic vein, we stand the chance of causing puncture of the hepatic vein. Now there can be complications related to the variceal embolization, because normally the embolization is done post tips creation. At times the coils can migrate because there is a reversal of flow into the varices. So you can see this coil has come back. So we need to take in the snare and pull back the coils. There can be vessel trauma, and the important thing about post-tips liver ischemia, as Dr. Jain had mentioned, it's the buffer arterial flow which sustains the liver post-tips. In cases of, as the child status worsens, this buffer goes down. So that's why the child C status will have poorer outcome, may end up more with liver ischemia and infarction as compared to a child's A. But if this happens, we do not have much option rather than other than either occluding or downsizing the tip stent. As you can see in this particular case, the patient had landed up with encephalopathy. So there are two stents which are in place. One is a 6 mm balloon mounted, and the other is a covered stent graft. This is the final outcome, the covered stent graft being opened after the deployment of the 6 mm bare stent, and we can see that this area of the previous stent now doesn't receive any flow, so we have already downsized the tip stent. Otherwise, you can create your own techniques whereby you have tied a thread into the stent and then recaptured it into sheath and then deployed it. There's another particular stent called Atrium, which is not available in our country. That opens up from the ends. It's a balloon-mounted stent. So you open up the stent at both the ends, and the central area remains narrow. Again, downsizing the tips. This was the patient which I had shown earlier. The same case where we have occluded, we have downsized the tips. At times, because of encephalopathy, you may need to occlude the tip stent. You can use Amplatzer plugs or covered stent grafts, coils, and the results are good. Once you have done that, the encephalopathy can be reversed. Radiation is something that we need to take care of during tips, because the procedure can range anywhere from 9 minutes to 330 minutes as per literature. So if you're using high dose of radiation, you're not only exposing the patient to radiation risk, but to the radiology workers also all around. That's the grading of radiation injuries. In case we expose the patient to more than 2 gray, we need to counsel the patient and tell them to keep a follow-up with a dermatologist at least from about 2 to 6 weeks later on. So I conclude my talk with the note that careful attention to procedure technique is vital to avoid the complications. However, when complications do arise, it is essential to remember not to panic, consider the case thoroughly, admit mistakes, react appropriately with best interest of the patient in mind, and learn from the experience. Thank you.